సర్జరీలో ఉన్నారా హేమనాథ్?
Sir?
Can go live, sir.
Yes, sir. Right. Okay, Rajendra, I'll start. So, good evening, pure FB viewers. So, today we'll have an interesting topic to discuss, and we have a renowned urologist, a senior urologist from Hyderabad with us to discuss this topic, that is pressure rise in RIRS, how to prevent it. Dr. Kashinatham sir is with us. I'll introduce Dr. Kashinatham sir. He is a consultant urologist working at Yashoda Hospitals, Malakpet, Hyderabad. He did his MBBS from Guntur Medical College and MS from PGI and MCH from SWIMS. He has done over 600 renal transplants and over 100 laparoscopic donor nephrectomies. His area of expertise is laparoscopy, endourology, supine PCNL with ultrasound guidance. He is a recognized DNB teacher, mentored over 10 batches of urologists, and he is the recipient of Best Paper and Best Poster awards at AP Sohas conference. His original publications on the role of he has original publications on role of laparoscopy in stone disease, and he is a former AP Sohas council member. So today we will discuss one of interesting topics, that is pressures raised during RIRS, which is one of the most important causes of sepsis during RIRS. And I will hand over the program to Dr. Kashinatham sir. Sir, please, you can share your screen, sir.
Is it visible, Hem?
Yes, sir, you can maximize the screen.
Full screen.
Okay.
Yes, sir.
Hi, good evening, everyone. As Hemnath has already introduced about me. Hemnath, is it audible?
Yes, sir. Slightly louder, sir.
Okay. So today, Chandramohan has given me a topic to how to reduce renal pressure and temperature so that you can do RIRS safely. As you know, with advent of flexible ureteroscopy, RIRS is done in everywhere. During initial period, when the RIRS introduced, only Chandramohan was doing. Now, everywhere RIRS is going on. Even if you go to a district place, even if you go to a small town, everywhere RIRS, everyone is practicing. So when we do this many large number of cases, there is every tendency for to develop complications. So doing safely that procedure, even if you do a procedure, it is far away from your hospital, the patient should be safe. That is our goal important. So to prevent complication in RIRS, unlike PCNL, we are not worried about bleeding much in RIRS. The main complications with RIRS is sepsis and complication related to ureter injuries like that. Okay. So pressure, what is pressure? If you have pressure in your blood, you can call this hypertension. If you have pressure in your mind, it is called stress. If you have pressure at your workplace, it may be called as tension. If you have pressure at home, you can call it as a torture. If you have pressure in your kidney, you can call it as an increased intrarenal pressure, which will give rise to complications. So wherever there is high pressure, there is every tendency to develop complications. Okay. So pressure देना क्या है, not लेने का. So reduce pressure wherever it is there, so that you can practice safely and you can move forward. So when we are doing RIRS, the ultimate goal is to clear the stones. The small target is 20 mm. So if you big think, it is 30 mm. So clearing 20 mm, 30 mm stones with RIRS, the roll of PCN is slowly decreasing down. So do this procedure at the same time without having complication. That is our target. At the same time, that finishing time also very important. If you go on whatever the procedure, whether it is laparoscopy, whether it is other surgeries, usually we keep BP at 90 and time of surgery 90 minutes. So even if you take this 90 minutes, even for TRP also, we'll consider 90 minutes as a limit time. So wherever you do the procedure within 90 minutes, 90% of the times you won't get any complications. So keep this in mind and proceed. So the safety, the procedure of the safety is also very much important. And at the same time, nowadays the problem is if you say the patient multiple settings in it, most of the patient will go to others. And single setting, that the target of our need is to the procedure in a single sitting. And in future, especially when we are sending PCNL patients on the same day, we are also expecting same thing in RIRS also. So the target is to get minimal complications with greatest gain. So what happens during RIRS? Why we are so much worried about RIRS for sepsis and all these things? Before going into deep, the normal intrarenal pressure will be around 0 to 15 mm. So when we are doing RIRS, the pressure will rise. It may grows to 35 plus or minus 10 during diagnostic RIRS. But when you fragment the stone by applying pressure, by applying laser, the pressure may rise to 55 to 20. So the worry is with increased pressure, this pressure is transmitted into pilotubular system, pilovenous system, lymphatic and sinus, which are the main culprit for these complications. If the pressure is around 15 to 20, it causes pilotubular reflux. If it is more pressure like 50 centimeters, even the pilovenous reflux can come. This diagram you can remember, the pilotubular, pilovenous, pilosinus, all these reflexes, all these are caused by raised intrarenal pressure. So what are the main factors which leads to these complications? Either increased pressure, at the same time when we are using laser, the temperature rise. As we know in urology, we use different types of energy sources. We use sound, we use light, we use current. So similar way, when we use laser, when we are using light, there is every tendency to raise the temperature. So these also causes complications. So raised intrarenal pressure, raised intrarenal temperature. These are the two culprits for the development of complications during RIRS. So how do you reduce these pressures? How the intrarenal pressure will rise? It depends upon the inflow and outflow. As you think, how you decide your bank balance? By input and output only. If you put 1 lakh rupees and if you remove 50,000, only 50 balance will be there. Similar way, if you increase more fluid intake and less is coming out, the pressure will rise. So what are the ways to give saline irrigation in the RIRS? Some persons will use Pathfinder. Many of them might not be knowing this Pathfinder. I will show you in the next images. Then you can rely on a good assistant giving with syringe slightly irrigation according to the need. Other thing is you can believe on gravity also. You can put the saline to 60 centimeters, 100 centimeters, that gravity will help you. Otherwise, you can use pump. These are the 4 important ways how to irrigate the system when you are doing retrograde intrarenal scopy. The other factors which will decide the flow, that ureteroscopic size. So the initial flexible ureteroscope size was big. Now the scope size comes with 7.3 size and now even 6.3 size. As we know, recently our Chandramohan has done 6.3 scope surgery. So in future, everyone will get that scope so that the irrigation flow depends upon the size of the ureteroscope also. Then at the same time, the working channel, whether you are using the working channel for diagnostic and whether you are using laser stoning, that also will affect the inflow. The last factor is recessive index of the kidney. So if you are doing a small kidney and you are doing RIRS, definitely the intrarenal pressure will be high. If you are doing in a RIRS in a very large kidney, definitely it is very difficult to raise the pressure. Similar way, the outflow, whether you are using access sheath or you are not using access sheath. So recently we have done one study. We have done almost 80 cases, primary RIRS without access sheath with minimal complication. So what are the precautions if you are doing a primary RIRS, just like that someone has done, you cannot go. You have to take all the precautions. What precautions you have to take, then only you proceed. Other thing, primary or secondary, whether you have put stent before or stent not, that is also matters. If you don't put stent, if you are passing a scope into that one, it is like you are going on a small narrow road with your car. When you put stent and you do surgery, it is like you are going on highway. So it is very easy to drive on a highway. So similarly, the procedure also, if you are doing primary, definitely you will have some problems. Secondary, usually the procedure will be very smooth. Second thing, what are the size of the ureteroaxis sheath if you are using? If it is a small scope, definitely the outflow will be less. If you are using big size of the scope, flow will be good. But to use big size of ureteroscope sheath, usually it is a secondary procedure, not like the primary procedure. And recently, we have come up with the fans. So there are many number of fans per fans. The first fan is Chandramohan only. Okay. The next part is PCN, whether to put any small needle through the kidney. So many of the people, many of the surgeons may not accept this putting PCN, but I am the fan of PCN, putting a small needle. How to measure intrarenal pressure or temperature? So you are talking this many things. Is there any measure to measure this pressure? How much pressure it is raising? So what are the modes? Because our scope till now is not having any sensor to identify these pressures and temperature. So you have to have some way like using PCN tube, or to some sensor on the scope, or to through the working channel. The working channel should have a pressure monitoring system, or ureter access sheath itself will have some sensor. So in future, we may get all these things so that we can continuously monitoring the pressure during surgery, and you can adjust the inflow and outflow system so that you have a procedure continuously monitor. Like when we are doing CABGs, cardiac surgeons are doing, they'll continuously monitor the rate. We can also measure continuously temperature and pressure in future. So this is basic guidelines to identify how much flow it will comes if you use a different one. If you have a pump, you can fix the flow. If you have a good assistant, you can fix him. But if you are using a gravity, if you are using a 60 centimeter height, routinely we use for TRP 60 centimeter height only. Because that is a TRP set, that is a big size of bottle, the flow will be very high. But if you are using any 1 liter saline, if the 60 centimeter height, the flow will be around 10 ml per minute. If the height of the bottle is around 100 centimeters, the flow will be 20 ml per minute. This is a rough guide so that when you are doing the procedure under gravity guidance. So the main thing is when you don't use ureteric access sheath and you use a 10, 20 ml or 50 ml syringe and goes on pumping saline, the pressure in the renal system will rise, especially if you are doing primary RIRS without doing access sheath, the pressure will rise to hundreds. So that will the main culprit for these complications. This is one study they have mentioned, flexes to scope. If you give 8 ml per minute with 20 cc syringe, the pressure will be 330 millimeters. You can imagine. Even with 30 pressure, there is a pilovenous reflux will be there. If you have 330, you can expect what the complications going to be. So on a rough guide, if you put 100 centimeter height, it is approximately 10 to 20 ml per minute flow will be there. Without access sheath, the pressure will be 100 centimeters. With access sheath of 10 to 12, the pressure will drop down drastically to 30 40 centimeters. If your access sheath is 12 to 14 size, it is around 14 to 15 centimeters pressure. At the same time, whether you are using fiber in the working channel or you are just diagnostically doing also does matters. When you are doing, most of the times we are breaking stone. So most of the times the working channel will be engaged with the probe. With probe in situ, the pressure raising will be very difficult because the flow won't be that much high. So these are the main important factors to raise up the pressures. Inflow and outflow balance should be there. So then you will control the intrarenal pressure. The other thing is raising of temperature also, because we are fond of high intensity lasers nowadays. Initially we have only 25-30 watts. Now many are using 40, 60, 100 watts also. With increasing energy levels. So the main problem with this is increasing in the intrarenal temperature. This is also one of the most important factor which is culprit for complications. It will cause renal damage and especially bleeding. So in this year also, flow is very important for intrarenal temperature maintenance. Inflow and outflow monitoring also important. And second factor is laser. Which type of laser you are using, how much energy you are using also important. And third thing is type of the fuel for irrigation. Nowadays, some of people are using cold saline for irrigation to decrease the intrarenal temperature. But the studies are not yet confirmed whether it is safe for the patient or not. And one more study is use of antibiotics to prevent septic complications. So nowadays, we are started one thesis topic for our student, use of antibiotic during irrigation. As we mentioned initially, flow, inflow, constant mind, constant thinking about the flow, pressure during inflow and outflow is very much important during the procedure. This, just see the laser. If you increasing the energy levels with more and more 40 watts, 60 watts of laser, if you use 20 hertz laser energy, the energy which reaches the stone is around 50%. But if you increase the frequency to 80 hertz, only 4% of the energy will reach the stone. So what happens to the remaining energy? That will raise intrarenal temperature. Many times you come across when you are doing RIRS, when the outflow is coming through the access sheath, it will come very hot water. So what happens? The water is boiled, even tissue will be affected with that one. The important thing here to measure is how much of joules energy is required for a 1 millimeter cube of stone to ablate. So if you use high energy lasers, definitely wastage of energy will be there, which will cause more and more joules per millimeter square of energy is required to ablate the stone. So which will increase intrarenal temperature. If you take 40, if your temperature is raised to 43 degree temperature degrees, to damage the cell, it takes 240 minutes. But if increase the temperature just to 10 degrees, the time to damage the cell will be only 15 seconds. So this matters. So you have to balance between the flow and you have to balance the energy what you are using. So this is a rough guide. When you're using 10 watt energy, use 10 ml flow, 20 watt energy, 20 ml flow, 40 watt energy, 40 ml. If you use, the temperature will be less. But it is, you have to assess IRP also, not IRT only. Because if you are using high energy levels, if you increase the flow, you may decrease the temperature. But at the same time, it will increase the intrarenal pressure. So there must be balance between the energy and flow is must. So after doing all these discussions, what you can come across is if you use 20 to 30 watts lesser energy with lesser flow around approximately 15 ml per second, it will be safe both for pressure and temperature. One more thing, when you are doing surgery, when there is a big stone is there, there is every tendency to continuously use the laser. So which will raise the temperature. Like if you think coagulation, cutting, as we know in monopolar, if you have continuous current, it will cause cutting. If you cause interrupted coagulation, it will give coagulation effect. Similar way, if you give a small pause during laser, definitely the intrarenal temperature will come down. And there are many number of studies have shown that if you take a small pause of 3 to 4 seconds, the temperature will drastically come down and the complication will definitely come down. If you want to use more energy, give a small pause. So take a small break when you are doing a procedure. Don't continuously goes on hanking the pedal. So this has been this ODC has been assessed. ODC means if you continuously using means 100% ODC and is a continuous laser. You are not raising your pedal from the foot from the pedal. But if you use only 50% ODC means you are using only if you have 1 minute lasing time is there, only 50% you are using. Throughout the cycle, you are using only 50% of the laser only. So with ODC 50%, the complication will be definitely come down. Operator dependent cycle it is called. Then I have initially mentioned that to decrease the temperature, whether we can do chilled water like that. So there are few studies out there, but we can protect the kidney. But what happens, whether this cold fluid is absorbed into the body, whether the patient body temperature will come down, we don't know. So there needs more studies to prove this. And at the same time, using antibiotic in irrigation fluid also, there are studies are going on, and we are also starting one study on this. So we have to come up with this, whether to, especially this effort to decrease septic complications. Last one is the fans. Fans means there are different sizes of scopes are there. I don't know whether many people are doing this is as a primary, I don't know. But if you want to use big size of the scope, most of the times it will be after putting stent. So the advantages of flexible scope is it is a big size and you can reach the calyx everywhere. At the same time, you can increase your irrigation at the cost of less raise of renal temperature, less raise of intrarenal temperature. Because the outflow is good, intrarenal pressure won't rise. If the outflow is good, temperature won't rise. And at the same time, when you are using suction as your secondary energy, secondary importance, that fragments and dust will come out and the vision will be good. When the vision is good, there is no need to increase inflow. So all these factors, initially when Oliver Traxler was presenting in a conference, he was very much against suction. But nowadays, everywhere suction is there. So you can suck the fragments and dust so that your vision will be very good and you can proceed continuously. Initially, many people are saying what is it, what is the success rate definitions. Nowadays, they have changed to grade A, B, C, D success rates. Even they don't want to leave a small fragment dust also, especially after coming up fans. Because initially we used to think about the success rate after 3 months. Nowadays we are thinking on table and within 1 month also because of these fans. If it is grade A, there is no fragments, no dust, everything. If it is grade T, single or multiple 2 to 4 fragments. So you can gradify your success rate also. This is just for the new entry students. What is the fans? You have to see this. You can see the access sheet on the above and this collector will be there so that you can take the fragments. Many times when the patient asks where are my fragments stone. So you can collect when even if you are doing RIRS, you can collect the fragments and give it to patient. So practically, I just want what we routinely practice, I want to show you. So for every patient in our practice, in our center, whether you are doing ureteroscopy, whether you're doing RIRS, whether doing PCNL, the position of the patient will be same. Supine PCNL position. For every patient, we will keep like that only. So this is the basic position. So the same side of the surgery where we are doing, the leg will be a bit down. The other side, the leg will be higher up. And only small sheet of bed sheet, roll it and keep it on the right side on the patient back. That is the only procedure we need. And the same side of the hand will be put on opposite side. For every patient, whether even you're doing URS also, we apply this position. And to prevent problem with the C-arm, we have cut that stirrup into small size so that the even stirrup won't hamper in your way. These are old flexes too, and many are not using now. Everyone is using now digital scopes with 7.3 size, and in future 6.3 size. Many were expecting this size of scopes. Similar in PCNL also, initially everyone using 20, 21, all big size scopes. So now everyone is using 16, 12 small scopes. With decreasing size of the stone, complications also will decrease. These are the three things many of the people might not be using, but still we are using these instruments to decrease all these complications. So one is balloon dilator, one is pathfinder, one is LP needle. This is the Alkan's dilator. Sometimes when the stone is very big, when we want to do continue with the RIRS, even sometimes we'll put small cube so that it will remove all the fragments and dust and sometimes even pus also. So this is a small video. For every case, whether we do URSL, whether we do RIRS, we regularly dilate the system. So with this size, even the VJ orifice, the dilatation will go up to 18 French. So that putting an access sheath, whether if you don't put access sheath, if you want to do primary RS also, it is very easy for us. So many may not accept this balloon dilatation, but with 7 French balloon dilator, we use it because we are the teaching institute. We don't want to have any VJ complications because hundreds of ureteroscopy and hundreds of RIRS done by our students also by the time they complete their MCH course, DNB course. So if you dilate this, most of the time still not, we have not seen any ureteric injuries like avulsion, all these things, even from our side and from our student side also. So this balloon dilatation we have learned during our MCH course and we are practicing still. And it will give rise to this image, this grade 0 ureteric injury. Only small petechiae will there. There won't be any mucosal injury. And the other armamenting our institute is to use ultrasound. So for every we'll put ultrasound, we'll put 2 monitors, or 1 from down, 1 for T-cell. We will keep ready. Whether we use or we use. So every case we will be ready with like this. So that if you want to attack the stone at the ureter, you will attack. If it is not there, you can go RIRS. If still you have any problem, you can go for supine PCNL. Still, if you have any problem, even if you want to do laparoscopy or open, this position, this I can call it a universal position for stone disease. So this is the image guidance. Can you see that there is small rectangular shape? When I put the probe, I will see this rectangle always. So our puncture should be within this rectangular line. So then when we see the bowel, when we see the liver, when there is a window is there, that rectangle shape only will select as a window for that one. Then we proceed with the puncture. Why we are doing puncture? Small puncture with LP needle. Single writing or but RIRS is going on. It will decrease the intra-renal pressure and it will decrease the intra-renal pressure. When the stone was very big, more than 3 centimeters, sometimes we can use Alkan dilator also. When we see from inside, when we confirm that the puncture is through the papilla, we can easily dilate to whatever the size extent you need. But if you don't want to convert into PCNL, many will say that why don't you convert it to mini PCNL? Yes, this option is always there, but we can just dilate 1 or 2 extra dilatation, put that one and complete with the RIRS. A small puncture. We have finished the stone. So we could finish that this much because we are not using thulium laser till now. We are using holmium 25 watts only. If we have a 30 watts, 40 watts thulium laser, it is very easy to clear all these fragments within no time. Sometimes when you feel that something pus is left over, something is you are feeling about whether patient has a tendency to get fever post-operatively, we'll put small PCN tube also. And you can check for any injuries or extravasation like pilovenous reflex or any injuries there by giving contrast also at the end of the procedure. So to reduce pressure, this is a small image I want to tell. When you are doing TRP, if you are using storage instrument, there is no problem. The outflow is very good. But when you are using other instruments other than storage that make up similar to storage, most of the times the inflow will be good, outflow will be less. So many times, almost 90 to 100%, I will practice this. I will put a small needle once the bladder is filled. It is continuously the drains from above. Even if you big gland more than 100 grams, you want to clear it in a single sitting without doing interrupted flow. Even sometimes I will do SPC 10 French or 12 French Malikat catheter also. So this is a small study we have done.
సార్ ఇప్పుడు 40 కంటే ఎక్కువ సార్ కొంచెం వాటర్లో పోలిస్తే అంటే మనకు పైలో
57 వచ్చింది ఫ్లష్ సిస్టమ్.
పైలో లింఫాటిక్ రిఫ్లెక్స్ లైట్ గా వస్తూ ఉంటుంది సార్.
So we have done a small study. We have started how to measure intrarenal pressure by putting small LP needle as we routinely doing that case. We have attached that sensor what the person used for arterial cannula during transplant of the major surgeries. Anesthetists will put arterial line and they will monitor the NIBP, not NIBP, it is invasive BP by attaching small sensor to that intraarterial cannula. Similar way we have put that small that attachment sensor to our PCR needle. Then we have measured the pressure. So when we are doing only diagnostic URSL, it is around 30 to 35 pressure, as you have seen that small video. And when we are irrigating with 20 cc syringe, it has raised to 50 to 55. So similar way we have control. Continuous monitoring also IRP can be done with this small needle puncture and during RIRS so that we can control the intrarenal pressure with minimal complications. The only worry thing is why you are puncturing kidney, whether you have any complications. The answer is we have done more than 600 to 700 punctures till now, whether you believe or not. Till now we have not had any complications. 20 or 18 size you can use. And if you feel that something pus is more, system is some infected, but still you can't to proceed RRS, the patient is stable, you can increase that size a bit more and drain the system during RRS. And if you want to convert it to mini PCNL, always everything is ready for you. You can just proceed. Thank you.
Thank you, sir. It was a very nice, wonderful presentation, giving a lot of practical points on how to reduce the pressure during RIRS. Sir, some questions, sir. So this needle technique, what you are telling, so you do for patients who have poor outflow in the access sheath or for routinely for all patients, sir? Or
When we
for
are-
large stones?
For last only, even small stones also we'll put ultrasound always ready. When you feel that vision is not good, the dust is disturbing, if the pressure is not there, immediately we'll put puncture. We are always ready there with ultrasound for every patient.
Yes, sir. With the advent of the spans coming up in a big way, do you feel that whether to put this needle or just to stent the patient and stage for a fans procedure would be better, sir?
If you have your own nursing home, you can do two stage. But in practice, like Yashoda and other corporate situations, patient most of the days, even periphery also they are not. If you put stent, they are asking that is the failure of surgery. And we are not considering the patient, but many will expect that you please complete the procedure in the single sitting.
This preoperative counseling is important, sir, for staging of RIRS or RIRS may be converted to PCNL
Yes,
if they want in a single go. You do that for all patients, sir?
All patients will tell, every patient will tell all the complications and the procedure what we are going to do, even conversion to PCNL, even multiple sittings. Instead of telling all that, whether you believe it or not, our primary RS success rate is more than 95%. We are not doing secondary. If you think of secondaries, very few cases, maybe in once in 3 months, once in 6 months secondary. Otherwise, all the RIRS, our case is primary only.
So any tight ureter also you force actively dilate
But,
and then
even sometimes we have dilated VUG and we have dilated ureter also. And if sometimes it is not going access sheath, we'll do directly without access sheath.
is there any Stricture rates, increased stricture rates following these kind of active dilatation, sir,
No,
in your experience?
we have not seen any patients till now.
So usually our primary RIRS rate is around 80%. We don't actively dilate the ureter. If it allows 6 by 7.5 ureteroscope, we proceed with the RIRS. Otherwise, we'll usually stent and stage it
Yes,
after
that is always is not. We are not against secondary procedure only because of circumstances given. We are proceeding.
What is your advice for upcoming urologists, sir, whether to do active dilatation or to stent and stage the procedure?
If you are at periphery, you are not have all the facilities. You have not good assistant. Put stent and come out. Do the procedure. If you have all the facilities like us, you have a good assistant. You have a good system. You have a good then proceed with primary.
Any experience with this integrated scope, sir? Now Biorad has come up with integrated scope, including this pressure monitoring and also this temperature monitoring. We have tried that scope in few cases, and whatever you told, that theoretically we were able to practically observe those things.
Okay.
So any experience, sir, with that scope?
No, till now we didn't get. We are 6.3. We are ordered, but 6.3 also now come.
Size is slightly larger, 8 French scope.
Oh,
We have
scope
to
is bigger size for that. Oh, it is again difficult. So I won't buy that.
The sensors are integrated in that scope. So by the side of the monitor, by the side of the processor, you will have the separate monitor for this, a small one.
Okay.
You can have the real-time pressure and also real-time temperature inside the system.
Okay.
And whatever you're told theoretically can be observed with that. This needle technique you told us, that can be uh, avoided, and we can integrate this scope also if you want to have a study on
The 8 French is
study on
that
pressure monitoring.
that size. Again, we are going back to big size scope. It is again you are going to get complications, and the primary rate will be come down.
I'm afraid of this punctures left, right, and center you are doing for all patients.
Yes.
Any complications, sir, like bleeding or any?
No, till now, we have not seen even a single complications, and you can say that it is zero. There is no bleeding till now, no bowel injury, no liver injury till now. More than, and I feel I'm saying 600. We have done more than that also. From
Sometimes
last
they say
almost to
that
2020, we are
one
practicing.
puncture also can cause AV malformations or
Oh
pseudoaneurysms
no,
or
we are
something.
doing an ultrasound guidance. We are doing transpapillary puncture. It is exactly perfect transpapillary puncture. We won't go into in the infant,
Dilate
even
the
fornix
system with
also we will.
saline. Dilate the system with saline and then puncture ultrasound guide.
No, when we put RIR scope itself, the system will dilate.
Okay.
Before RIR scope introduced, after introduced, the anatomy and ultrasound will drastically change. We'll keep probe ready. Once the RIRS enters into the system, the dilatation will be very nice.
Yes.
Initial duration of it was taken 15 minutes to puncture. Now it is less than 1 minute. And even our residents do puncture within less than 5 minutes. And they're worried whether if we are doing GOSA like this, we may forget for prone PCNR. And CN guided puncture also.
Okay.
They're worried whether
So,
we will become ultrasound guided and supine pro.
so fans, primary fans rate, what is your experience, sir? How many percentage of patients you could able
Yeah,
to do?
actually, as I'm using this needle and these things, I have not used pants much. If you believe or not,
Fans.
we had only 2 or 3 cases with pants. That's it. Yes.
So,
This we
any
have this anyway. We are suction for this. We have used this also. That suction within the scope, it is there. That
yes,
also
yes.
you can use if you don't want to puncture. Some dust you can aspirate with the interrupted suction on the scope itself.
Sometimes these needle punctures can cause a little bit of maturia, so the vision
Bleeding.
gets blurred during RIRS.
Yes, that will be there. But most of the times with ultrasound punction and
Even with
what
perfect punctures,
it
there
won't.
may be some hematuria, some bleeding going on. This
Yes.
RIRS vision can be affected.
But most of the times we puncture with small 20 size initially. And if the system is directed, we puncture with 20 size. If we more, there is 18 size. And when we see RIR scope from inside, when you feel that the puncture is so papillary and it's not bleeding, vision is good, then we'll increase the size. And even if you want to proceed with PCNL, proceed it within no time. We'll put guide wire and dilate it, and smallest size of mini scope will do it. And many times what happens, the stone will be in the upper calyx sometimes. So that flexible, it is like ECRS, as you know, regularly we are doing practice. Upper calyx stone may not be reachable with miniscope, then immediately the flexible will take care of that upper or lowermost calyx stones.
So what's your antibiotic protocol, sir, to prevent sepsis? What do you follow? Single dose pre-operatively or post-operatively also you
Yeah,
can
I will
take?
give most of the patients OPD basis. I will start all the patient nitrofurantoin before itself, and we'll give one magnet shot just before surgery. And we use isopamycin during procedure when we feel that something infected adenovirus is there. Isopamycin we are regularly using.
Okay.
One dose of isopamycin.
So any
Puncture, after
cases?
puncture, definitely there is a decrease in number of fevers. Initially during summer period, as we know, every patient, even with do VUJ calculus, they will get fever. The think about RRS. So there's continuously 3, 4, 5 patients. If it comes fever, your physician won't refer patient to you. So that's why we are worried about. So when we have started doing this procedure with needle puncture, fevers definitely came down. We have already that thesis. My student has completed that successfully.
No increase complications with the.
Complications rate, fever and septic complication fever has drastically come down.
Do you tell the patient that we'll put a needle previously or
We'll explain the patient. And one more thing
explain?
is,
People
because when
used
we
to
say the
accept that,
patient,
sir.
if needed PCNL, we'll sell it. And
No,
one thing
people
is the
used to.
advantage with the LP needle is, even if you puncture, there is no need for any 11 number blade. It just feels like spinal needle. It is a spinal needle only, it's a wedge shape. And you won't see the marking of needle also.
You don't give a nick in the skin, just a
No
direct
need at
needle.
all. No need at all. Directly you can puncture from anywhere and you won't see. It is like just like IV cannula. When you put IV cannula, you can see mark. But with
You
LP needle,
don't
you
give
won't see
stab
what is it.
incisions before the
No,
puncture.
not at all. No, not at all.
Directly. Okay.
By free-handed puncture and without anything, and just needle will pierce like anything, just like butter. The needle will go like going to butter. And many feel that it will injure more kidney like that. But still now we have not got any complication with the needle.
Thank you, sir. Any Rajendra, any questions from the audience? Anything is there?
Checking, sir. One second. There is no question, sir. From
So we'll conclude, sir. It's a very nice discussion. Thank you once again for your participation, sir. Thank you, sir. Thank you so much.
Thank you. You are good job, Hemant. Hemant, you are doing very much good job. And very much impressed with you. And before closing, I just want to talk about CM. Whether it is many people are talking, what we can call urology as a before pure and after pure. I always say this point because
Yes,
any person, any young urologist wants to, once they have completed DNB or MCH, when they want to do practically something point, if they want to know about some penile process, if they want to do RRS, if they want to do PCNL, if you follow the pure, you can get all the information from different experts without any hesitancy. And you can practice it practically because our CM, he always wants practical things only, not theoretical.
our topics are all mostly
Yes,
not theoretical. We avoid theory topics.
theoretical. Yes. That is very much useful after completion of DNB and MCH. And many times when we go for surgery, also we'll go through this video and what senior most person has done, we'll see and proceed. So definitely it is going to be a lot of help, and we can call before pure era and after pure era.
Thank you so much, sir, for your kind words. Thank you, sir. See you, sir. Bye.